Great. Hi, everyone. Thank you, Neil and Cindy, for both organizing the course and inviting me to speak. And it's a pleasure to be here. As Neil pointed out, I was here at Stanford not too long ago. I did a PhD here. And today I have the opportunity to talk about a company that I founded as I left Stanford that's now often doing AI for healthcare. And more specifically, natural language processing for healthcare. So I will deliberately avoid making this a sales pitch and try to talk about some general problems. I will touch on some specific things that we do and completed projects we've worked on. But the main emphasis here is, I started this company because machine learning and AI have tremendous potential, and they have tremendous potential in a lot of industries that have yet to go through their sort of AI revolution or data-driven revolution, if you will. I'll start by acknowledging that just about everything I'm going to show you today is not my own work. It's the work from the tremendous team that we've built at Rome. That team today is about 50 people. Not all of them are shown here. That happens a lot in startups. It's hard to keep track of pictures of everyone together. But as an organization, we've been around for about 4 years. We're a late-stage Series A in startup terms, so we've raised about 25 million total. We already serve customers, and importantly, we focus exclusively on healthcare. Some background on how I got to have the opportunity to work in a company like that, let alone start it. I was an undergraduate at Carnegie Mellon, and given the events of this weekend, I'd ask everyone to keep the people of Pittsburgh, Carnegie Mellon, and Jewish communities in mind. But at Carnegie Mellon, I studied computer science and mixed in some psychology, cognitive science, and neuroscience because it has really interesting overlaps with AI, and I didn't really know it at the time, but it sets up sort of an interest in health and related fields that drove to part of what Rome is today. I came to Stanford. My dad was very happy because he didn't have to pay tuition anymore in the PhD program. But I started my PhD in computer science around 2009 and had a once-in-a-lifetime opportunity to work in Andrew Ng's group, more or less exactly coinciding with the modern rise of deep learning. So my first NIPS deep learning workshop was about 50 people, and the main topic was, why does no one outside of this workshop at NIPS care about deep learning? I don't really go to NIPS that much anymore because it's just thousands upon thousands of people doing deep learning applications, and instead I focus more on health conferences and health data conferences as well. Started Rome as I finished my PhD. As I said, worked with Andrew Ng primarily, but Dan Jurafsky was a co-advisor, tremendously helpful in understanding what my dissertation topic ultimately became, which was spoken language and deep learning's role in spoken language. And now I still do teach occasionally as a visiting lecturer, so CS224S, Spoken Language Understanding, every so often. So, AI can transform healthcare. That's great. That's why we're doing this course. That's why this course is one of the more exciting courses at Stanford, I hope, this fall. But how? It's different than maybe some of the previous talks that might have focused on, inventing new drugs or other admirable sort of grand endeavors that AI can certainly help with. As a startup, you have to focus on nearer-term problems that don't require a huge amount of money to solve because no one will give you that money when you're starting out. But you can start by looking at the healthcare system. So the healthcare system in the US, extremely large, extremely costly. Healthcare system globally, still very expensive, but as we look globally, you might think less about sort of cost and overuse and more about access to care. And my claim to you is that you don't need to invent new AI to have a tremendous positive impact on healthcare. And in particular, you don't need to solve some of the really sort of socially hard problems that we think about when it comes to AI in medicine and AI in healthcare. We don't need AI doctors. We don't need AI to tell us which drugs to invent, or even to invent new drugs. And why is that the case? And to be clear, I'm not saying that AI shouldn't be used to do those things. I'm only pointing out that if we look at the grand problem of healthcare, then AI can play a huge role in what I refer to as data-driven healthcare systems. So a data-driven healthcare system enables us to use data to improve delivery of care, resource allocation, and things like prevention, so that without the invention of new medical breakthroughs, we can actually reduce a lot of cost and improve outcomes for patients. So specific types of data-driven healthcare system outcomes we might hope for. Well, we can make doctors and nurses super intelligent so that they spend less of their time scanning through documents or completing mundane tasks, and spend more of their time with the things that they're uniquely good at, which is comforting patients, helping patients understand treatment decisions, and so on. We can also improve access to care and quality of care by, again, automating or digitizing some aspects of healthcare. And finally, probably the most important thing we can do with AI is keep people out of the healthcare system, because any sort of health economist would agree that once someone is admitted to the hospital, you're sort of down a path in terms of cost that you would rather not be on. And so that's things like, how can we use ambient intelligence? So how can we use the Google Home or the Amazon Alexa or your smartwatch to help you better track and manage diet, exercise, other behavioral factors, as well as detect potential problems early on, so that people aren't going to the hospital when it's already too late to avert a high cost problem or a bad outcome. Doing all of these things requires quantifying patients. So being data-driven requires data. And as a really simple example of that, if someone walked into your doctor office, if you were a doctor, and you were only able to access demographic information about that person, so you might say this is a male aged 30 years old, Caucasian, and that's all I'm going to tell you. What disease does he have? Or what drug should you prescribe? Really tough problem, but keep in mind when we're talking about machine learning systems, if you don't explicitly give them access to input data that captures the patient in the way that you want to understand the patient, then this is basically what they're trying to do. So a good first step is, let's take all the sort of data that we're already capturing, sort of, and see if that's a sufficient representation of a quantified patient. And sadly, especially to the people who are sort of new to the healthcare system, coming from a technology background, very bad news about what the healthcare system so far has done in terms of data capture and data processing. They did not historically, especially in the US, think about long-term sort of secondary uses of data. So much of the best data we have in the healthcare system today is insurance claims data. It's accurate because if it's not accurate, no one gets paid. That's a good reason they keep things accurate. Unfortunately, it's not a very comprehensive view of a patient, and it's certainly not a very comprehensive view of someone's health. And again, any researcher who's worked with insurance claims data can probably provide you with a long list of things that they wish they could also analyze, but simply can't because insurance claims data don't measure it. And we might think that electronic medical records could be the answer. And again, we, in the US especially, created a lot of regulations so that we have these things called electronic medical records. Unfortunately, we didn't really incentivize filling them in properly, and we especially didn't create systems that allow us to capture accurate information. And so again, if you attempt to do data science on electronic medical records and just assume that they're sort of correct or a complete representation, you'll find that even within the same system, so your Epic system or your Cerner system, depending on what hospital is configured entirely differently, the physician workflow is entirely different, and therefore the data that's created is, again, quite different. This is a problem as machine learning background researchers. I think we tend to underappreciate this problem, but again, people from kind of the med school side of campus can probably provide you with a very long list of frustrations with their EMR, especially if they've used it for data science. So AI has tremendous opportunity to help address these problems, and that's sort of foundational, because if we can't quantify a patient, then building a predictive model on top of what we know about that patient isn't going to help us all that much, no matter how good that predictive model is. So Rome's focus is in the area of language, and we think a fundamental piece of this equation is language data. So language data refers to text, audio, recorded interactions between people, recorded interactions between humans and chatbots even. And it is wonderful because it is really easy to collect. Everyone in here, if you have a smartphone and a laptop, you have two of the best microphones that you can imagine relative to 20 years ago. To capture far-field audio, we can now speech transcribe that audio. Really the missing piece is how do we take all of that language data and use it to start quantifying patients in a better way. And again, this doesn't require some complex physician workflow change in the way that a new EMR system might. Language data can be really minimally invasive to capture, although it is hard to process. So here's an example of clinical text, just to quickly level set in case people have not seen something like a doctor note before. We'll come back to the details of this encounter, but just quickly to point out, this is sort of fake structured EMR data. Obviously there would be a lot more, but often the notes section of your EMR will contain very comprehensive statements like this. For patients with complex diseases, the notes section of their EMR might be hundreds of pages long by the time they're finished a long hospital stay or over the course of multiple encounters. And we seek to develop assays. So as a really quick test, a very simple assay is to measure our heart rate. We can find two fingers to the neck, count for 15 seconds, multiply by 4, and you now have an analytic procedure for capturing some data, processing that data, and obtaining an estimate of something you're interested in that case, your heart rate. So this notion of an assay is very familiar, especially in genetics, where we do not do whole genome sequencing just to test for the presence or absence of a gene like BRCA if we want to identify cancer risk. Instead, we would develop a specialized test that looks just for BRCA. That specialized test is itself, again, what are called assays. So it's a general sort of concept. It applies to a lot of different types of data, and the kind of overall flow is always the same. We start with some underlying thing that we're able to observe or measure. Oftentimes, the history of medicine has taken huge step forward when we're able to measure a new thing, like when we're able to sequence a genome for the first time. But we use some combination of data capture and data processing, sort of in just caricature kind of here, in order to obtain some information about a target phenomenon. And at Rome, we're really excited about the future of language assays for healthcare specifically. And all of these trade off So in much the same way that we wouldn't want to sequence your whole genome simply to obtain the presence of one gene, we might not want to fill out a large survey or checklist to obtain a list of someone's symptoms. Instead, we might ask the patient to narrate their symptoms, or we might simply make notes as we have a normal encounter with the patient and use a language system to automatically detect presence or absence of a particular phenomenon about that patient. So some specific language assays, again, there's things like complex symptomology that we can only measure through language effectively, because otherwise the doctors will never fill out the checklist. There's also things like rationale for treatments that really can't really be captured in any other way than asking someone, because fundamentally, if you had a checklist for possible alternatives, it wouldn't be sufficiently comprehensive compared to allowing someone to just provide an oral justification. First, we can look at a mental disposition sort of assay that's been developed, and this is what the output or what the sort of function of a model that we develop might do. So in this case, we're looking at a patient's mental states in addition to negations of those states, and there's some other categories here as well. You might ask how these categories came to be. They're defined through an annotation scheme that is sort of targeted for the task at hand. So in this case, this model is part of just some research and demo work, which is why we're able to show it. And originally, I think the annotation guideline, so what comprises a mental state, was defined by one of our clinical data scientists working with some of our clinical annotation specialists on our sort of data labeling team. A similar assay we might sort of develop and deploy are around lifestyle factors. So different diet and different exercise patterns. And again, this is a different sort of model. It was developed with a different sort of targeted purpose. And what this model is then doing in the end is it's scanning over the text and it's able to identify these different spans and assign categories to them. And how we measure sort of quality of these models is just how well they match the performance of our clinical annotators. Because some of these concepts are inherently ambiguous, and so the agreement between different human experts might actually be very low. In those cases, you wouldn't expect a model to sort of perfectly recognize something. If it's just fundamentally an ambiguous concept, the model is going to end up sort of uncertain in many cases as well. And when we kind of put a lot of this together, we can, one, superimpose a lot of different models, so a lot of different sort of targeted concepts. And the other thing that you'll see here are these sort of blue arcs. So these are relations. So in addition to a model just sort of going through and highlighting a span of text and outputting a category or associating a category with it, it can also link together some of those different categories. And that's what a relation is. So on that lower right-hand side, we see that this planned treatment, a laparoscopic band, is justified by, that's that sort of relationship, I believe, justified by or supported by a weight gain. And that makes sense. This is why that procedure is happening, and the relation allows us to sort of structure that data. And we wouldn't be a proper startup if we didn't show you a live demo. So this is one of our internal kind of model running platforms. I'll paste in that text we were looking at, and when I hit predict, these different 4 models along the top will all sort of run their inference procedure against this text. Oh, and I might have to log in again. basement Wi-Fi is the extra challenge here. There we are. So I pasted in that text, I ran predict. We can see these category labels. Many of them overlap. Again, that's because, so here we have like 2 treatments. That's because we have 2 different models in this case that are both looking for a treatment category. This is a live demo, so we can do fun things like look at, something like a reason span. So due to her weight, we might replace with, I don't know, from stress at work. How about? Predict. Here, what actually happened was it switched from a reason category to domain. Domain is actually a more specific category, so that allows the system underneath to observe that these 2 mental states, frustration and unhappiness, might have a relationship to this specific domain. And again, the output categories here are sort of defined by the annotation guideline itself, and if we don't like them, we'd be free to sort of invent a different version of this model with a different schema. And yes, I'll fully acknowledge you can break these things. So, 78 pounds. If we took this system to Europe and people started measuring things in kilos, we would be confused. And again, this is purely an artifact of, these are just demo models that were built on texts that only had pounds. That's an important thing, I think, to keep in mind when you're starting machine learning companies and building machine learning systems, is you have to be aware of what they can and can't do and how well you expect them to generalize, and design your sort of product and application around that. And one word, people in the research community here might be familiar with systems like CTAKES or NCBO Annotator, which was actually partially developed here at Stanford. Those are phenomenal tools, especially for the research community where budgets might be limited. What we do at Rome is sort of fundamentally different, because systems like CTAKES and related are sort of pre-built. So they have some pre-specified notion of what they're looking for, and oftentimes they're fairly simple. So they might automatically extract all drug names. At Rome, our platform and tool sets are much more focused on developing and deploying customized models. So rather than just recognizing a drug name, we want to look for specific drug prescription reasons in this case. And it's just sort of working with different building blocks, right? So as a researcher, some of these pre-built systems, they might be a great start. However, if you're really going deep on building language systems, I encourage you not to rely just on sort of pre-built and actually look into more specialized language extraction. So what can we do with this, or what have we done with this so far at Rome? We've worked and continue to work with a pretty wide sampling of partners and clients in the healthcare space. Language data is everywhere. No one knows what to do with it for the most part. And so at Rome, we work with life sciences companies where we help them sort of monitor the voice of patients and the voice of doctors for their treatments. We also work directly with hospital systems and other types of providers to allow them to have a better quantified representation of their patients, to do data science or population health, as well as automating some really mundane decisions like whether or not a message needs to be reviewed by a doctor or an administrator. Finally, we work with sort of data partners or other players in the space like American College of Cardiology, who, as part of their service to cardiologists, create a large outpatient registry, and that is ripe with opportunities to improve what we know about the practice of cardiology through extracting additional information from language. Unfortunately, I can't talk about a lot of these things. That's why a lot of these things are Fortune 250 pharma companies, sadly. But I'll try to give some examples where I can. So this is one project that we completed and presented at the AIDS conference this year. This was joint work with ViiV Healthcare. They're one of the leading providers of HIV medications, as well as Optum, who's one of the leading providers of data for electronic medical records in the US for study. And in this project, we're seeking to better understand why patients already diagnosed with HIV fall out of care or do not maintain adherence on their antiviral medication. So in HIV, if you're staying on therapy, the therapies that exist today tend to be quite good. But if you stop going to the doctor or stop filling your meds, you can very quickly sort of progress and have viral loads that are too high. So in this work, and the full poster is available online, we showed that just the clinical notes section of the EMR, so that's this clinical only on the right, that allows you to predict with very high, that's AUC, but you can think of it as accuracy, very high accuracy whether or not a patient will maintain viral load suppression for 6 months. And in fact, if you use just the notes, you actually can better predict whether that patient will stay virally suppressed than if you build a predictive model on the structured data from the EMR. Of course, your best model is when you combine the two, but it's really interesting to see that the notes that providers are making are actually a better predictor than all of the structured data that we have for those patients. There's details in the poster and kind of the intuition as to why that happens. It's not because the notes just re-encode everything that's in the structured data. Instead, the notes reveal things like undiagnosed mental health disorders or home stability issues. And those have a huge impact on whether or not someone will remain adherent to medications and really don't have much of an analog in the structured data. For example, discussions of sort of depression come up a lot, even when the patient has no formal diagnosis of depression. And you would need a formal diagnosis to see that in a structured insurance claim code, for example. With life sciences companies, we work with data from their inbound call centers or data from their medical affairs representatives who are going out and engaging with doctors in the healthcare system. And we can process and extract information from a lot of notes that are being generated in that overall system, and then create some dashboards that allow them to track trends over time. And yes, I worked on sentiment here at Stanford. Some people might have used the movie review corpus that Chris Potts and I put together. When we say sentiment in healthcare, we mean something very different than awesome or terrible. Sentiment can mean very complex sort of decisions around a particular drug or side effect. And again, in those cases, we can develop some of these sort of targeted language extraction systems and then track and sort of slice and do data science on really complex phenomenon rather than just letting these notes sort of sit idly by while important trends in medicine are sort of undetected. And finally, we get to do really fun research at the same time. Again, NLP in healthcare is really challenging and unique. And for me, coming from a speech recognition background, that means your research plan or your research answer doesn't always have to be build a huge neural network. Oftentimes, building huge neural networks is the right thing to do. but there's a lot of space to play and do research and really understand how can we take machine learning and natural language processing techniques and make them work really well for healthcare applications. So to wrap up, there's great applications in AI doctors. There's great applications in inventing new drugs and automating, really complex parts of the health system. However, keep in mind that the healthcare system is really kind of inefficient and slow to adopt technology. And when we think about AI applications, you might find that some of the biggest impact things you can do are automating or replacing or changing some of the really mundane aspects of health. And a final sort of word, so I wish this class existed when I was a PhD student so that I could have learned some hard lessons for free. Given many of you are Stanford students, I'll repeat some advice that my advisor Andrew Ong gave me as I was thinking about starting a company. And it was, think about what you want to do at Stanford. Use Stanford as the tremendous platform that it is in order to really understand problems, meet collaborators, and work on something before you sort of take the leap into startup world. Because the lessons you learn at Stanford are much cheaper than the lessons you learn after you raise a lot of money. And when you're at Stanford, you're sort of this neutral party, and everyone will talk to you and tell you about their problems in a way that when you're a startup, people tend not to. I especially love StartX. We, as a company, went through StartX just as we were forming. StartX is a nonprofit that's very closely tied with Stanford, and they're sort of an accelerator, but they don't take equity. And they're a fantastic network of founders, Stanford alumni, investors, and advisors. We continue to use them to this day. And finally, think really hard and understand about what being a founder of a company means. Because if you're lucky, you'll go from working on some exciting technology to waking up one morning and being on the board of a 50-person company. And so you should know what that means, and you should take those things seriously. And it's fun, but it is different than whatever you have in mind now as you get the company started. So I'll say thank you again to the phenomenal team that allowed me to show you everything that I've shown you today, and take questions. Oh, and attendance code. Yeah.
I got a chance to talk to your co-founder Alex this summer, and it was really fascinating what you're doing. The question that I have going back to healthcare, EHR, is accuracy of the medical records. And what I mean is, a lot of notes are open-ended. The doctor will review the patient, come up with a diagnosis, give a treatment, and if the patient doesn't come back, doctors tend to assume, hey, I was right, but that's not always the case. And so how is that an error you guys are worried about? Is that something that can propagate through your data?
Yeah, I think there's kind of two questions there, or two aspects to that. So broadly the question was, EMR data tends to be really ambiguous or open-ended, and part of what you touched on is an issue of longitudinality. So if I prescribe you a drug and you take the drug and move or just switch health plans, I might never know what happened to you. That's an issue. One way we can kind of address that issue actually in language data, one of the things we see in a lot of doctor notes is a history of present illness. So rather than having to piece together your actual encounters from 5 different health systems over the last 5 years, in that notes field we might be able to get some important information about your personal history, your family history, and so on. But for the issue of longitudinality, I think that's a fundamental challenge that I hope, or I wish, sort of policymakers might address. I think if we had more sort of prioritization of longitudinal health records, we could do a lot of data science with them, and it's not really clear who does that today. Although the shift might be that consumers start doing that through things like Apple's like mHealth and so on. Other questions? Yeah?
Given your access to data and the systems that you have in place, why haven't you started to make some really interesting discoveries about things in healthcare? You showed me some research that you found, but as a company, do you find that for your own good or ethical concerns you're confident in what you're able to report to the outside?
Great question. So we have lots of data. Are we sort of limited in what we can report or what we can analyze about that data? There's a lot of layers to healthcare data use and reporting things. So primarily as a company, one of the things that we emphasize is that we're a tool set. We're not a sort of back-end data aggregator. So when we start working with a hospital system, their data and all outputs of it are sort of up to them. In the same way that if you were using Microsoft Excel, you're not sort of, Excel, as we hope, is not copying that data on the back end and using it for other things. Although, depending on who you're working with, so when you work with a pharmaceutical company, they have some regulatory obligations to report things. And so, again, we're just a tool set that they use, but they are actually bound to make sure that things do get reported or not, so that they're not suppressing information. And finally, I think I didn't really touch on this in the kind of starting companies, but access to data is a real challenge in the startup world, in healthcare especially. You have to think really hard about why a large hospital system would trust a small startup with their full EMR data. How can you prove that to them? And so that's, again, one of the reasons why things like accelerator programs can be good. So you can go and help people work on their data in a more friendly scenario before you're the Cambridge Analytica of healthcare nebulous entity. Other questions? Yeah?
Considering how quickly research develops in machine learning in general, do you find it a challenge to keep up with research when you're developing your tools?
Is it a challenge to keep up with research as we're developing? Not so much. I would say that the areas of research you track might shift, but if you're taking this course, I hope you start a company and sort of find a product path where you force yourself to use some of the latest quality research. So much of our text extraction systems wouldn't be possible if our team wasn't capable and had already built in their past some really complicated semantic parsers, for example. So I don't track for deep learning research as closely these days because many applications that Rome works on require non-deep learning systems due to data set sizes and things of that nature. But I personally I still review for a lot of conferences, and as a company we do things like journal clubs and submit papers exactly because we want to be in touch with the research community.
The majority of approaches, at least that I've heard of, healthcare tend to be around computer vision. What was it that drew you to NLP rather than computer vision and the other type of approaches in that field?
Yes, why NLP and not computer vision? Because a lot of radiologists will tell you their assessment of the value of computer vision systems for radiology, and often they judge them to be quite low. So there's a lot of areas where machine learning can do something. It might be able to do it as well or better than a person, but you really have to step back and look at sort of the overall workflow. And in the history of us as a company, actually when we started out, we were just more focused on kind of machine learning and data science on structured data in healthcare, and we went further and further into NLP as we found that just the structured data was so bad that if you wanted to get real signal, you had to look at things like provider notes. I can't see that well, so if there's other questions, feel free to shout. All right, thank you everyone.